CME in ethics is going to become compulsory. And we all have done medical ethics training somewhat during our undergraduate days. Most of us have done it during our postgraduate years, but I think SMC felt that there was a requirement to have some refresher in training in medical ethics and professionalism. Hence, the requirement to have compulsory CME in ethics starting from next year. And next slide, please. James.
Thank you.
Yeah. Just get the slides going. All right. James, you're controlling the slides. Next slide, please. Therefore, the Medical Council decided that they would engage the three professional bodies, SMA, the Academy of Medicine, as well as the college, to deliver the ethics training for the subsequent year, starting from next year. And I think the three professional bodies will do it directly, as well as in collaboration with other institutions. As far as the college is concerned, we will be, the three professional bodies, first of all, will be doing basic ethical principles during the first 2-year cycle. And subsequently, the subsequent years, we will expand into topics more contextualized to the area, respective areas of the three PBs. So as far as the college is concerned, we will be focusing on family medicine. And we'll contextualize the subsequent CMEs to that. So for college programs that we have planned next year, it will come out in the calendar towards the end of the year. So we are planning various activities as far as ethics is concerned, mainly case-based learning online, webinars such as the one that we are doing here. We will also have a skills course that we will do towards the middle of the year. Skills course will be following the format that we have for our other skills courses that we run by topics. And so it'll be quite interesting through a series of activities planned by the college next year. But today's webinar is actually a primer for subsequent teaching activities for next year. I think, just a minute, the slides are not moving. Can we stop? I think, James, can you stop screen sharing and start again? Right, okay, thanks. Next slide, right. The next slide, please. Okay, so for today, we have a very interesting webinar, which will be the primer for subsequent teaching activities next year. And what we've done is we have two sections. The first section, we will discuss general challenges to professionalism, ethics, and law. And the second section, we will have actually a case-based discussion, a very interesting case that would be relevant to all primary care physicians, something that we will see in our daily practice. Just a little bit of housekeeping. First of all, please turn off your videos to protect your privacy. And you will get 2 CME points, but you need to attend the whole 2-hour webinar. And you don't need to clarify further your MCR number on the chat, because we have your MCR number on the registration. So you will get your CME points. Now, there will be a Q&A function where you can type in your questions, and we will answer these questions in tandem to some of the main points that we are covering during this webinar. Right. In the interest of time, we might not be able to do live questions, but we will address those questions that you type in. In case that we can't answer every single question, we will definitely try to get through the most relevant ones. Okay. Next, please. Okay, without much further ado, let me kick off the first half of this webinar. And we are going to be talking about challenges in primary care for professionalism, ethics, and law. We have a very interesting and very experienced panel. Dr. Tirumurthy is no stranger to all of us. He's a dermatologist by training, but he has been involved in ethics and professionalism teaching and training for a good many number of years. And you would have seen him in many activities in all the 3 professional body activities. Prof. Goligan is also no stranger to all of us. He's a very senior teacher in family medicine, and he has also been involved in ethics teaching and training for a good number of years, both in the college programs and without. Wong Tianhua is the current president of the college, and he is a GP in the private sector, again, dealing daily with ethical dilemmas and medical decision-making, same as the rest of us. Dr. Swat Teck Sin is a senior consultant in the public sector, also been involved in many years of teaching ethics and professionalism, and we value his inputs as well. Last but not least, we have Mr. Lek Siang Peng, who is a lawyer by training. Mr. Lek has also been involved in various training, teaching programs for the 3 professional bodies in ethics and professionalism. And he's also one of the legal counsels for the college. So he will bring in very interesting viewpoints from the legal perspective. Now, without much further ado, we can now start off the session. I thought that first of all, we will start off with a question of the very topic itself, professionalism, ethics, and law. And sometimes some of us are not sure what each of these mean or how these are intertwined and how they are related to each other. So to start off with, what is professionalism, ethics, and law, right? And how we can better understand their interaction. I would like perhaps to start off with Dr. Thiru to help us explain this concept. Dr. Thiru?
Thank you, Suraj, and thank you for having me for this afternoon's discussion. Can we just move the slide, James, the next one? So I think when we talk about professionalism, ethics, law, you find there's a lot of lack of clarity in terms of what these are, and they overlap, right? And so what I would like to do is to put it into a house. We call it the systems that govern healthcare. And the systems that govern healthcare really are one that involve doctors and the practice of medicine. And now when we practice, we are actually not practicing alone. We are also practicing under cover of an organization. Even your own clinic is being registered with the Ministry of Health. So professionalism, ethics, and law applies directly to doctors and the practice of medicine. And the other aspects, as you can see in healthcare organization, there are equally important areas of clinical professional governance, risk management, which overlaps with professionalism, medical ethics, and law. I will take on having this sort of overview in terms of where we want to park the concept of professionalism, ethics, and law in our practice. Can I have the next slide, please? So really, I want to give a definition. There is no one universal definition. So you will have many definitions, but generally what we use in the SMACM is really to look at a multidimensional concept, which includes duties, competencies, behaviors, virtues, outcomes, and relationships that are related to medical practice. But what is the most important thing is not so much the content of what is there, but it's actually what is the aim. The aim of professionalism is to achieve the goals of medicine. And the other major aim in professionalism is to promote trust and confidence in the healthcare system. Let's take a minute to understand these 2 important points, why they are important for practice of medicine. Next slide, please. So the goals of medicine, it looks obvious, but it's always worthwhile reviewing. It's about prevention of disease and injury and promotion and maintenance of health, the relief of pain and suffering by maladies, the care and cure of those who are affected by maladies, and those whom we cannot cure, all right, there is care, all right, and this, of course, now we not only talk about curative medicine, we talk about palliative medicine, we talk about end-of-life issues, rehabilitation. So we have a whole spectrum of care that we provide for our patients, even if we don't cure. And then basically, and especially when you reach the limits of biomedical medicine, the avoidance of premature death, but we also accept that death is an inevitable end of birth, and therefore we would have the pursuit of a peaceful death. So all these goals that we want to achieve, what professionalism does, it facilitates us to achieve this goal in an efficient manner. Next slide, please. So let's take a step back. I think we put all the slide, click on to the full slide is there. So let's take a step back and say, okay, what is this source of goals of medicine? And I think this is a good time for us to really step further deep to understand what is the philosophy of medicine, where is the origins of medicine, and where does the origins of professionalism come from. So I put out there as three core elements. One is the presence of human suffering. I think in nature, there are many diseases and illnesses, and it's inevitable that humans continue to suffer from this. And this is something that we understand and accept. Now, then comes along the healer. All right, the healer observes the human suffering, and then in his heart, he feels a compassion, and then he has a thought in his mind, oh, I want to go and help this guy suffering, right? And then he signs up for medical school, and that's how all of you became doctors, and then you are now practicing medicine. So really, the core of the healer is in compassion, right? In response to the suffering. But there is a cognitive component and a competence component there. And then the whole healing process and the outcomes. And that's really the practice of medicine. So really, medical professionalism provides the framework for governance for the compassionate healers to practice medicine effectively. So I think that professional identity of us as being both professionals and a healer, I will deal with in a little while. Next slide, please. So again, let's look at trust and confidence. Why trust and confidence is important? We understand that medicine is a complex scientific, there is a social component, there's an ethical component. And because we are dealing with human beings in suffering, there's complexity, uncertainty, and there's continuous change, and there's ambiguity. And many things are probabilistic and really uncertain. Now, therefore, in this area where we have so much of uncertainty, trust is necessary to establish stability and consistency in medical practice to achieve the goals. So what is professionalism exist for? Professionalism exists, and we subscribe to it because it provides the best platform and the components to build this trust. Next slide, please. So there are many other ways of looking at professionalism. And of course, one of the well-known ones is this Charter of Medical Professionalism, which was enunciated at the beginning of this millennium. And more than 80 or 90 countries and professional bodies have already accepted this as our working charter in terms of what, if we analyze what are the commitments to professionalism based on three fundamental principles and the 10 commitments. And we'll discuss some of this in the next slides. Next slide, please. So, but today, all right, professionalism is now actually codified into law because doctors had demanded for licensing. They wanted to be differentiated from charlatans. And as a result, when licensing came in, all right, then it became codified in law. So professionalism is a basis of the doctor's contract with society, but is codified in law, and in Singapore is under the Medical Registration Act and taking the Singapore Physicians Pledge and conforming with the ethical code and guidelines. And that holds us accountable for what we do. And it is essential in this contract that public confidence and trust, both in individual physicians and the entire profession, is really central to this. In other words, our duty in professionalism is to uphold the public confidence and trust in our profession and our individual physicians and practice. Next slide, please. So when we look at the components of professionalism, when you call yourself, I'm a healer and I'm a professional, all right? There are many other forms of healing sciences and healing professions, but ours is one of a healer and a professional. And that requires certain things. Number one is clinical competence. We have to make sure that our biomedical science, our medical practice, our diagnosis, the treatment is actually doing things right, okay? And this is governed by professional standards. If there are no standards, there is no professionalism. So a professional aims to achieve the professional standards in his performance of practice. And it is important that we be aware of what the professional standards are and to have the competence to meet these professional standards. So that's one block to it. Then, of course, we, like in the charter, we have a whole area of literature, you can say, which tells us about our duties, responsibilities, and how we should conduct. And this is then monitored all right, and we'll later talk about professional misconduct, and that is really the professional accountability and governance. And this professional accountability, remember, originally it laid with professional bodies. So when a doctor was not behaving himself, he lost the membership to his professional body. But today, there's law, we would have a greater risk of losing your license or being suspended in our professional accountability. Then it is not only doing things right. We have the other arm of it is really about uh, doing the right things. That means whatever we do must do good to our patients and must be something that is valuable and good to society. So the third arm of professionalism in not only clinical competence, ethical competence, is this strong sense of altruism and service. Why is a professional different from a businessman? In the sense that a professional, the social value of his work is uppermost in his mind, and the economic gains are secondary. Whereas in a business entrepreneur or entrepreneurship, okay, the economic gains can sometimes be overtake the social value of the products and services we provide. And then, of course, among our relationship with our own colleagues, it's a culture of collegiality and collaboration. In fact, I would dare say there's actually very little competition among colleagues. Our only competition is against disease and ignorance. And therefore, this concept of collegiality and collaboration is a very fundamental ceiling and part of our professional concept. And finally, to maintain clinical competence, we have a continuous learning and improvement and a commitment to excellence. We are not committed to perfection. So doctors are not expected to be perfect, but we are expected to actually continuously improve our practice as our experience increases. So the next slide, I think I've come to the end of, oh yes, okay, one slide is missing. So anyway, that actually covers what is the concept of professionalism. And let me now quickly share the two other points about the concept of law ethics and in medicine and the law. So ethics actually comes from philosophy. It's a scientific study of morality. And basically, ethics is the study of that science. It's what is a responsible evidence-based analysis and an emotional evaluation of what is actually good based on virtues. We can talk a little bit further on this, but often these are in guidelines, and the SMC Ethical Code and Guidelines has a lot more information there. I think we are going backwards somehow or other. Okay, so there are a couple of terms in ethics, and I think I'll just want to introduce three terms now. One is bioethics, all right? The bioethics is an overarching field, all right? It's a large field the large house that contains several other ethics. There's clinical and professional ethics. So bioethics is really the study of ethical issues in biotechnology, biological, and medical knowledge, research, and application. And in Singapore, we have an authority established by the cabinet. It's a bioethics advisory committee, and there's a lot of good work done by this committee, especially for people who are at the cutting edge of medicine and research, biotechnology. You can refer to the websites, and there are extremely good guidelines for that. Next slide. But for most of us as practicing doctors, there are two other forms of ethics we need to define. One is clinical ethics. Clinical ethics actually deals with ethical issues that arise in the clinical care and treatment of patients and the practice of clinical medicine. That means it's really the patient-doctor or patient-professional interface. There are a lot of disagreements, dilemmas, and issues that may arise. Then there is professional ethics. This is, again, as I said, go back to what we talked about in terms of the codification law. This is really what society expects our doctors in terms of duty, responsibility, and conduct. And this conduct is not only in terms of how we care for our patients, but also maintaining the trust and confidence of the public. in the profession. Next slide, please. So now I move to law. So the practice of medicine is highly regulated. There's statutes, common law, and regulations, right? Can you just click on to the whole slide is out, James? No, no. Next slide. No, yeah, okay. So really, the health law is one area that is concerned with laws governing interactions between patients and the public, with doctors, healthcare professionals, and healthcare organizations. And this is an area of law that we actually need to understand and have a good appreciation of how it works. Next slide. So click one more time. Thanks. So basically, we have in Singapore, the legal system we have inherited from the British. All right, and then basically there are two big components. One is laws made by Parliament, which is a supreme legislative body, and they are called then statutes or sometimes statutory law. But as the law that has been established by Parliament is put into practice, then in different situations allows the courts and the judges to interpret the law in different ways. And sometimes they do give certain guidance in terms of how a practice of medicine will occur. And next slide, please. And the law is, of course, confined to each jurisdiction. And therefore, if you are practicing in other parts or other areas, you have to be aware of the law in that situation, especially if you're doing international work or otherwise. But so when we look at law, all right, they're basically law that covers the medical practitioners, and this is something that we need to know about the Medical Registration Act. This is where our license is. This is where the accountability with Singapore Medical Council is, and the growth of the profession. Healthcare organizations, right? We have the Healthcare Services Act, and then basically there are many other acts. I'll just give three examples, but there are many more, including the Mental Capacity Act, Vulnerable Adults Act, which all influence the practice of medicine and to some extent guide the way we practice medicine. So there are basically three groups of laws, one governing the professional, one governing organization, and one governing the practice. Next slide. Okay, so actually I've ended my presentation. I hope I've given you a good overview of where we are going to park this professionalism, ethics, and law. It is about governance, it's about growth, it's about nurturing, all right? It is about being able to practice effectively and efficiently, okay? And then there is the component we talked about in the relationship between professionalism, ethics, and law. Over to you, Suraj. Thank you.
Thanks, Dr. Thiru. That's very comprehensive. And I hope the audience now appreciates the differences or the nuances of the professionalism, ethics, and law. But having now looked at that, how do we then apply the concepts? So perhaps I can now throw the question to the rest of the audience, starting perhaps with Prof. Goh, how we can apply these principles. Prof, can you give us your take on it? Yeah, Prof, you have to unmute yourself. Yeah. Yeah. Prof, you have to unmute yourself, I think. Yeah. Yeah.
Good afternoon, everybody. Yes, so this question of how would you apply concepts of medical professionalism, ethics, and law in our daily practice is a question that we could address. Next slide. So I want to first look at professionalism. Okay, so professionalism need to look at in the context of ethics, as Dr. Thiru has presented to us. And if you look at ethics, you can scope it down to 4 principles in scope. So autonomy, beneficence, that means doing good, non-beneficence, doing no harm, and justice. And the scope is the context. So this context can vary from situation to situation. So this is one sort of concept that we need to remember. Next slide. Okay, then we also need to look at it in relation to professionalism, and they're connected in some way, right? So autonomy in medical ethics relates to attributes of empathy, compassion, respect. So it is linked in that way. Beneficence is related to altruism. That means the healer has got no self-interest. The interest is in the patient. And also there is a commitment to excellence for the interest of the patient. Non-beneficence is to do no harm. And in that context, it is important in care, responsiveness, and sensitivity. Quite obviously, the care must do no harm. So that is something that is self-regulated. Finally, justice. So in justice, this thing called being just is being fair, both in the selection and distribution of resources, and also the important idea of avoiding discrimination. That means everybody is treated the same way. And to make this work, you need to have attributes of honesty, integrity, and accountability. So this then link the professionalism to ethics. Okay, thank you. Next slide. Okay, then we also look at it in terms of solving ethical issues. So there's this model by Johnson. Actually, it's only one Johnson. Johnson, Sigler, and Weasley, 4 boxes approach. And this is very useful when you have a complex situation. You look at 4 things. First, the medications. Let's take the example of a patient with a diabetic gangrene. Okay, the medical indication is that leg has got to come out, right? Patient's preferences, he may not want it. He said, heck, so I have to keep my leg. And so long as he is corpus mentis, his capacity intact, you cannot take away his leg, even though it's rotting away. Of course, then you try to argue with him, say, hey, look, the quality of life is no good. And then you also have contextual features where you actually get the significant others to try to persuade him. Okay, so that would be the situation. So you say, all right, at the end of the day, medical indications is 1 point. Patient preferences, is it for operation or not? Maybe 0. Quality of life, certainly if you don't take off the leg, it's bad. There's 0. And then contextual issues. So how do the family look at it? In this way, helps you to come to a decision and then solve the problem. As I said, if the patient is cognitively not impaired, he actually has a decision in his life. However, if he lapses into a coma, then the caregiver, the medical professional would have a chance to do the right thing. What they call a good medicine, bad ethics. So I thought this example gives you some idea of how you deal with the complexities and also the conflicting issues. Okay, so that is ethics in relation to professionalism. Okay, next one. Okay, then we bring in the law. Okay, so the law is known as the law of medical negligence, and it's ABCD. A duty to care, breach of duty, causation that must be proven, and then of course damage. So the important thing of this ABCD is that it is a very systematic way to look at. So what is your negligence and what is your liability? If there's no damage, then it's negligence. If there's damage, then it's malpractice. Okay, so broadly, those are some concepts to bear in mind as you sort of develop more knowledge as well as more understanding. And in the case studies, it becomes much easier to comprehend. Okay, next one. I think it's my last slide, right?
Yeah.
Yes, thank you.
Prof, thanks.
Yes.
Thanks very much, Prof. Perhaps now, 1 step further, I can ask our primary care physicians, Dr. Wong Tianhua and Dr. Suat Teck Sin, their views on, especially since we have talked so much about the concepts, and the application. But what is really important to you in daily practice? Maybe I can throw it to Dr. Wong Tian Hua first. What do you think is important in your daily practice about what has been talked about so far?
Yeah, thanks, Suraj. Yeah, I think there are two aspects I would say, because as doctors, we are kind of almost responsible for to be professionally accountable for almost every aspect of medicine, right? It's a heavy responsibility, but two aspects for me will stand out. One is in the aspect of patient care, and the other aspect is the integrity of the profession itself, that we sometimes don't think of. So patient care, of course, it's quite obvious. You don't do any harm to the patients, right? So that's a very simple ethical principle. But things like confidentiality issues are something that sometimes we may miss. Right, these are pitfalls, right? It's quite obvious that we want to keep sensitive information, to ourselves and make sure that there's privacy, and we are aware that patients don't necessarily want their information to be revealed to relatives or other people, so that's fine. But if you look at, for example, in terms of technology, right, like national records, electronic records, right, it can be gray areas, right, where confidentiality issues and privacy issues may be breached, and patients are not aware of them. And as doctors, we have to have a duty to explain to patients that some of these records, if they sign on any HR, they can be revealed to other people, and that could erode trust if they find out and they get very angry about it. So these are the things that we have to be very sensitive about. Then the other aspect is that of the profession as a whole, right? The analogy that I always say is that we are all in the same boat analogy, right? It's not that some of us are sailing in a yacht and others in a cruise ship, and I'm on a boat. We are actually in the same boat. So whatever happens to us happens to other people. And as doctors, we tend to forget that we just act every day in our own capacity, but there's impact on the profession as a whole. So things like honesty, truthfulness, these are things that when they come to light, gives everybody a bad name, right? So honesty, don't do anything that's fraudulent, right? Some cases of cheating, in charge and Medicare claims, these are very, very obvious examples I can think of. So once we violate these principles, it causes harm to patients, it erodes trust in the medical profession.
Thanks, Tian Hua. Maybe I can get Dr. Swat Teck-Sin's take on this as well.
Yeah. Thank you. Prof. Tiru and Prof. Goh actually have given the lectures, and they actually encapsulate what are the key principles of being a good doctor, good practice. So essentially, I also have two main takeaway points. Usually, I would focus on the clinical skills. That means you will need to be up to date with your practice of, for instance, hypertension, thyroid, or diabetes, or chronic care, whatever that may be. And also the basic skills of ethics. So it is very heartwarming that ethics has been introduced to undergrad and then even postgrad, and we continue to have such a dialogue. So as for clinical skills, we constantly have to uphold our profession in the practice of family medicine. What constitutes as the acceptable standard, what is required, what should be done, and what should not be done. So these are clinical skills that you need to uphold. And ethics, as for ethics, it starts with, for instance, attending such similar webinars or lectures to understand the principles behind the practice of medicine and how do you apply these principles in a very difficult situation. We can do that by case discussion, understanding the ethical code, ethical guideline, even understanding some of the guidelines and the principles are laid out by the Ministry of Health, for instance, like the guidelines on the abuse, domestic violence, the guidelines on the duty to report, and also understanding the basic laws that govern your practice, whether you're in a private or in the public sector. Just now, Prof. Tiru just mentioned a few of the acts, but actually there are so many more acts, like the AMD Act, the Mental Health and Care Act, depending on where you practice. You need to be familiar. There is no escape from knowing some of all these laws that govern you, and also definitely our ethical code, ethical guideline that actually governs the professional practice. So So these are the particular areas that you start off as a practicing physician. You will need to concurrently build up these two set of skills, your clinical skills in whatever area you do, and also understanding the ethics, which is the practice of the moral and ethical principles governing this, or ultimately to bring about the patient's best outcome, and also to uphold our profession. So these are the key elements that we constantly have to remember. Thank you.
Thanks, Dixon. Very good points raised by both Dr. Wong and Dr. Sua. There's a question in the chat for Prof. Goh. Prof. Goh, regarding your 4-box approach.
Yes.
Yeah, can you see the question? The question asked is...
Yes, yes, that's right. Well, the point is that there's this good medicine, bad ethics that Prof. Tan Siang Yong used to cite this case, which I thought is important in the sense that when the person has mental capacity, his decision is final, right? So he said, look, don't touch my leg. Yeah, technically, you don't like to touch the leg. However, we also know that this gangrene is going to kill him if we don't do something. So when he lapses into coma, that would be certainly the time that his a medical sort of treating people can act on the situation and salvage his life. So that is therefore given as a exception that the person that loses mental capacity, his medical sort of providers acting his best interest can do something that he may not like it. Of course, the point that the questioner asks is that what if he gets up and become angry with you? Well, certainly that likelihood is there, but it's probably not so high. He probably will realize that if not for the fact that the doctors operate, he's going to die. So that case has been used as a teaching case, and Prof. Tan Siang Yong is fond of citing that case. I thought that case is also very useful to understand the complexities of ethics and practice. Does it answer your question? The two way. Okay, Suraj,
yeah, sorry. Yeah, maybe I can ask Mr. Lek for his view on this as well. This case, it's a quick one.
Okay, yeah. So, sorry, I may be the troublemaker, but I have a slightly different take on it. Because when the patient, when he has mental capacity, and he has actually made a decision for non-treatment, then from the legal perspective, actually that decision must be respected even if he were to lapse into a coma. So you have to be extremely cautious here, that you don't know. You see, but however, what may be a difference is that if, let's say, the patient is having considered the full situation, the patient actually never fully understood the consequence of his decision made while he was so-called lucid, then assuming there does exist this situation where you are entitled to say, actually, it looks like the patient never took this into consideration, then in that kind of a situation, that only then there would exist some scope for the doctor to use best interest principles to actually intervene. Okay, but if let's say the patient, when he was making his decision, he actually considered all this, and he actually said something along the lines that, I know I'm going to die with gangrene. Okay, then it is, the avenues may well be rather close.
Thank you. Very interesting. I suppose there are lots of technical viewpoints for this case, and I think it has to be very carefully contextualized to the patient himself and the circumstances around the case. As even Sukyang has typed in that whether there is a pre-existing LPA for the patient, and you have to explore the family's viewpoints and so on and so forth. But as time is coming on, maybe I can just go quickly into the next question I wanted to pose, is what are the common pitfalls for doctors exercising professionalism in medical practice? Maybe I can start off by throwing this question to Dr. Thiru again. Then I'll open up to the rest.
Can I have the next slide?
Next slide, please, James. Yeah.
I actually want to share some thoughts, and I want to provoke. There are 200 of you, 197. In terms of what really the pitfalls are, I think over the years, somehow or other as doctors, we overview is that we are very focused on the biomedical skills, biomedical knowledge. We attend CME, and we think that by the by, all right, we can get along with ethics and profession and work it out. So I think this basically, what I think the first and most important thing is that if you want to be a rich and famous doctor, please practice by professional standards, because you will then have good clinical outcome, a good patient and clinician satisfaction, less likely to burn out, and build trust in relationship. So somehow or other, we don't seem to understand that concept, that really getting into the midst of ethics and professionalism and law and understanding and getting the skills and knowledge actually will give us a better life, all right, and a better practice. I think somehow around in the concept is not discussed in that way. And again, I think we are always keen to look at improving our clinical competence more than our emotional competence, right? And I think you understand that actually in the practice of medicine, effective practice of medicine needs emotional competence as much as, if not more, than clinical or competence or IQ. I'm not saying clinical competence, IQ. That means EQ and SQ is more important. I think that's one of our failures to recognize. And as a result, the whole group of us, we go into a state of denial, we ignore. When we ask people to go and study, do a master's in ethics and law, no motivation, right? To master this knowledge and expertise and experience. And all the time call people like Lex Xiangping to answer all their questions and let the lawyers solve their problem and ask ethical questions to lawyers. So I'm trying to be very provocative here. I think this is a good session. This is the beginning of a new era. My take, Suraj, is that our biggest pitfall is we don't understand the complexity of this, the value of this ethics professionalism. We don't make an effort to really master it, all right? And we leave it to other people and philosophers and lawyers to solve our problems. And I think that, to me, I think that is the biggest pitfall. And the final bit is, even if you go into this and study the knowledge, you have to change yourself. You have to improve your communication skills and other forms of expressing your virtues and values. And as Tianhua says, integrity is extremely important, right? Just because nobody is looking over our shoulder, we think we can cheat a bit. So I think, to me, it is that part of how we engage with this group of knowledge and skills. This is our biggest pitfalls. I'm stand here ready to be bombarded by anybody.
Maybe I can ask the rest of the panelists. There's not on the Q&A, but maybe Dr. Soa, maybe you can respond to Dr. Thiru. Would you have any views on this?
I'm not going to bombard Prof. Thiru. I was earlier alluding to the fact that we have to have these two sets of two set of skills. One is ethics and one is the clinical. So to deliver good medical care, the science of practice of medicine is your clinical, and the ethics is teaching you how in certain circumstances that you need to when can you deviate and when you should not deviate and when you should protect the patient. These are all very difficult discussions that we all have to be trained. Very much like you attend CMEs for clinical, you also have to attend sessions to upgrade the skill, to reflect on some of those principles and see how you practice. So in concurrence with Prof. Thiru, so I'm not going to be, I like to stand together with you to be bombarded.
Tianhua, do you have any comments on this?
Yeah, I think it's ethics and professionalism is also something that we develop as we mature as doctors, right? It's, you don't start off with everything you know, right? It's as you go on, you see cases, you think about it, but the awareness is very important, right? Awareness that these things exist, they are hand in hand, you know, to your own practice. and then you interact with your patients, interact with the other colleagues, you talk about cases, interact with lawyers like Lik Xiang Ping lah. Then you learn things from them, right? Professionalism, things like what to wear, these are small little things that you how do you present yourself, that actually matters. Actually, how you dress is actually part of professionalism. Nobody teaches that to you in medical school, right?
Yeah.
So you learn from each other.
Okay, thanks. So actually this brings it back to what we are trying to achieve today. I mean, in terms of CME for ethics, so what SMC is saying is now going to become compulsory. Is back to the roots of our medical ethics and professionalism, and to do the right thing and to be more aware. Now, I'm very cognizant of the time left, but I wanted to address the last question, one big question that is often asked by many doctors, and that's the topic of professional misconduct, because there's been a lot of publicity about the DTs and the doctors who have been gotten into trouble regarding professionalism and ethics. So maybe I can bring this question to Mr. Lik Xiang Ping to understand the concept of professional misconduct in relation to what we have been talking. So, Mr. Lik, maybe you
can thanks, Suraj. James, can we have the next slide? Yes. So, in essence, as you know, right, other than some of the purposes that the MRA is enacted to achieve, they also want to make sure that doctors practice competently. And when the need arises to actually step in to uphold standards, declare standards, and of course, ultimately, it is with the aim of making sure the patients are treated properly and to maintain confidence in the profession. Next slide. Okay, so where the Singapore Medical Council steps in its disciplinary role is when one of the following types of situation comes up. So you perhaps shouldn't be surprised nowadays that the purview is actually slightly broader than just clinical conduct. Okay, so if you look at that slide, you will see that the first three bullet points are actually dealing with things that are not necessarily in the clinical context. The fourth one, point D, is when there is this thing called professional misconduct. The SMC also incidentally tries to maintain standard by talking about professional services, but that is maybe a quality of professional services, but that's a slightly different topic. So what then is professional misconduct? Next slide. Okay, so this phrase professional misconduct, you will find it in the Medical Registration Act, which comes in the portion where when can the SMC through the disciplinary tribunal punish a doctor if this thing has happened. So because while they have mentioned this phrase, it's not really directly defined in the MRA itself, but through various cases of doctors whose cases before the SMC have come up to the courts have provided some sort of a definition. So there was more clarity after a case in 2008. So you see the citation in the case there. So they said there are at least two situations. That means this is not all encompassing, but there are at least two situations. The first one is where there is an intentional, deliberate departure from standards. Okay, standards of the particular specialty or the profession. So where there is an accepted standard, and yet the doctor deliberately departs. Okay, so that's one example. Now, then the second situation is serious negligence. Okay, so in other words, while the doctor did not intentionally depart, knowing what the standard is, but he was so negligent, so careless that it is considered unacceptable. So these are the two situations which currently fall within the definition of professional misconduct. Next slide. Yeah. Okay, so basically, understand that it is not, the SMC is not supposed to be punishing simple negligence, carelessness even. Okay, but they want to look at actually more serious wrong conduct, improper conduct in the clinical context. So they would actually go through the inquiry to find what is the standard and how the standard was actually breached. And sometimes where the consequence of the failure is very serious, then it actually goes a lot towards increasing the severity of the penalty. Next slide. Yeah. Okay, so this slide just simply talks about how when there's a complaint dealing with poor professional conduct, how they would determine it. So you can see establishing a benchmark standard. So you mentioned some of the speakers have actually talked about, hey, clinical competence and all that. What is the standard of care? Then they try to find out how much has the doctor deviated. Okay, and they also sometimes they also need to actually look at how serious it is. So you must have all three to meet professional misconduct definition. Next slide. Yeah. Okay, I've actually come to the end of it. Okay.
Maybe, Mr. Lee, can you give us examples of what are the common areas where doctors fall short and in terms of professional misconduct, in your experience, I mean?
Yeah, so actually, in the cases that have come up before the SMC, and actually you can find it in the SMC website. You can actually see the examples because since quite a number of years ago, they published the findings of these cases. And so when it comes to professional misconduct, what are the common areas, right? Actually, I'm afraid to say is basically every aspect of clinical practice. There are complaints of basically wrong diagnosis. But of course, in order to constitute professional misconduct, it must be wrong diagnosis, either because with all the evidence that is before the doctor decided that it should be something else. Okay. So diagnosis is an area. Another big and rather contentious area is that of consent taking. So if a doctor does not take a proper valid consent, it can, okay, in certain circumstances, amount to professional misconduct. Then you find also a number of cases where the treatment was erroneous. But of course, it's not just because there is a complication that has arisen in the course of treatment, right? That in itself does not constitute misconduct in every instance. But it must be the kind of treatment method that was so bad as to constitute misconduct. So actually, it does cover almost the entire field of practice. Yeah.
Yeah, that's very useful information. Maybe I can ask Tian Hua, what is his take on how doctors can, try to reduce this risk, having this knowledge of what constitutes professional misconduct. What would you do in your daily practice to make sure you don't get into trouble?
I think
practice.
Yeah, for me, I understand that the number one complaint against doctors is actually poor communication. So I'll just make it simple. I think you want to start from the basics. Is effective communication. So it's just basically fundamental thing like that. Even when you take consent, right? When you inform patients about all these things, it's about communication, right? It's about empathy. It's about being patient-centered. And explaining properly what are the treatment options and the risks. And if you have a good doctor-patient relationship because of good communication, I think I'm sure you agree that half the battle, or even more than that, is one. And if anything happens or if it's an error or mistake, patients will tend to forgive the doctor. So that to me is the number one thing that we should work on. Thank you.
Dr. Swa, you have any views on this?
Yeah, certainly I call that the communication skill. There's a whole lot about understanding about communication skills, not just verbal, but non-verbal language.
Yeah.
And so that's one thing that we have to continue to hone our skill. The second thing is really about understanding and be truthful to the practice. In other words, if you are unsure of something, then say you're unsure and just check it out and then get back to the patient. In other words, you have to serve the patient's best interest. So oftentimes we want to appear to be good and to be flawless, and then we tend to act that we know everything, and sometimes those erroneous kind of thought may land ourselves in trouble. So good communication skill, upgrading the skills, and just be honest with our patient. Then we certainly will avoid this kind of issues with the professional body. Thank you.
Thanks. Maybe I can add on to that, though it might not constitute professional misconduct by itself. The other thing that we should emphasize on is good record keeping, because when I sit on SMC complaints committees, medical records are very important, and very often they're quite lacking in some of the cases that we have seen. So doctors should keep good medical records, besides practicing all the other good, right things to do. Dr. Thiru and Prof. Goh, do you have anything to add to this?
Just want to share one word. I think relationships. So the whole of medicine, right? Building good relationships, repairing relationship when they are strained, and be able to strengthen relationships is one skill that will save you a lot of from any of these complaints or even risk of professional misconduct.
Prof. Goh?
Yes, well, certainly relationship is very important. I would also add communication. I think good communication, clear communication is also important. I think the third one that is also important is that whether you have the patient interest at heart. I think some cases run foul because the personal interest of the doctor hijack the whole situation, of course, let the doctor into trouble. So the patient's best interest is also very important to remember. So actually there are three things: relationship, communication, remember a patient's best interest as well. Thank you.
Right. Thanks, Prof. Just before we end, I know we are overrunning a bit, but I think there's one question that many doctors would ask. Maybe I can throw it to Dr. Thiru first. One is whether there's doctors face conflicts between medical ethics and the law. I mean, how do they resolve this, and how do they manage? Dr. Thiru, I
think we have the slide, right, James? Yeah. Okay. So I think this is a question that often is asked, right? Are there areas of conflict between medical ethics and law? Next slide, please. So I just share a couple of prominent things that we talk about now. I think generally law is based on ethics, right? And they actually march together to do good for society and to do good for individuals. But sometimes there are situations where what is ethical may not be, what is legal may not be ethical. So in Singapore, we have the Termination of Pregnancy Act, which can be requested by a pregnant woman irrespective of her age, all right? And basically, the law is premised that you don't want unwanted pregnancy. That's a social policy, and the premise that the fetus is not a person. But I think all of us know that termination of pregnancy is really controversial because we really don't know when does life begin, right? And when does a person become a person? Does it mean you're not a person, you're not alive? So the question of whether termination of pregnancy is a termination of life is really unsettled. So when there is this kind of a discrepancy between law and ethics, in professionalism, we allow for what we call conscientious objection. So if somebody conscientiously objects to participating in termination of pregnancy because of their own personal or religious belief, and they hold it strongly, then the profession does not impose them the duty to actually carry out such things, and allow them to refer the patient to somebody else equally competent to manage. The next one is really about what are there ethical issues that may not be legal, all right? I think you all are aware that in this world, there are a lot of ways people look at end-of-life issues. And one of the things that's talked about, and it's actually legalized in many countries, is physician-assisted suicide, which is illegal, all right? But if you look at patients, especially, and I put up this case here, of patients with neurodegenerative disorders, all right, who they are not really in pain, but they are actually deteriorating in their function and ability to interact. Then there is actually a strong reason to think about assisted death. And to justify that, we actually use the principle of autonomy. That means the patient must be fully autonomous. If he is not only having capacity, but he understands the consequences, all right? And it's quite clear that it is a fully informed, autonomous decision. And I think it is not just autonomy, but it must be accompanied by compassion, that you can actually see the person having intractable suffering as a result of his medical situation. And therefore, from the ethics point of view, there's a justification to actually support physician-assisted death. But I think in Singapore, you follow the law, okay? So even though you may ethically argue, I think the practice of medicine is quite clear. The law actually supersedes, in this area at least, of end-of-life issues, that any form of assistance by doctors is not acceptable. Over to you, Suraj.
Yeah, maybe I can round off with just maybe getting Mr. Lake's view on this. Yeah.
Yes. There's maybe I can illustrate it with a more less controversial kind of example. So I've come across a case where an anesthetist he decided in the call at the end of a surgery that he was supporting that he needed to insert a central line, okay, for the patient, because he said that look, this patient is shown to herself to be very weak, and she said might as well put in the central line because he thinks that something will happen. Unfortunately, the patient developed a complication of a pneumothorax, okay, and was extremely unhappy that how come you inserted a central line without asking me? So the doctor, he explained to me that he said that this patient, it looks like she's in a poor shape. But then the legal issue is then, shouldn't you have taken some form of taken consent for the patient beforehand? So where the doctor is coming from, you can understand his ethical concerns, right? He's doing it, in his view, in the interest of the patient. Patient is a elderly, so he felt that she would need it, okay, sooner rather than later. But we came out with a difficult situation because the patient was not in a poor state before the start of the surgery. Although there was something in the clinical picture that may suggest it, which then also is not very good for a doctor, because I said, look, doctor, if you think there was this possibility, maybe you should have taken a preemptive consent for the central line. So you can see sometimes it may not be necessarily be as dramatic as the patient-assisted death kind of situation, but even in the day-to-day treatment kind of thing, so you have to be a bit careful here. But there is sometimes a situation where the doctor's interest in taking care of the patient may inadvertently fall foul of the legal principle, which in this case is that, well, you shouldn't treat without consent. Yes.
Well, thanks very much, Mr. Lake. Okay, that rounds off the first half of this webinar. We have overrun a little bit, but very good discussion. And I hope the audience has learned a lot from this discussion. Now, I will just take a 5-minute break. We'll come back at 3:15 to carry on with the second half of this webinar, and that will be moderated by my colleague, Dr. James Cheong. Okay, take it away.
Thank you. Yeah. 5 minutes. Why?
Hi, everybody. So it's 3:16, so just 1 minute past 3:15. So I hope, James, I'm a family physician in private practice. I hope all of us today have found the first segment and the webinar so far useful and relevant to our work. I definitely learned a lot. And I thank all the panelists and Dr. Suraj for taking the first part of the webinar. So right now, I'll be taking the second part of the webinar where we'll really look into a particular area of medical ethics, and that's really something that we do every day, and that's really about patient confidentiality and of course privacy as well, and about disclosure of information. So I believe that last week we had sent out, you may have received earlier this week, a pre-reading material about a case study. So we're going to use that as an example or as a scenario to frame our discussion around this issue of medical confidentiality and also disclosure. I'm very happy to have with our panelists today in the second part, the case-based discussion. Once again, we have Prof. Thiru and Mr. Lik to join us in the second segment. And on top of that, we are very thankful to have Dr. Paul Goh, who's a very senior physician in public service, to join us today to share with him his experiences. And of course, we have Dr. Eng. Dr. Eng is a very senior GP in private practice, very involved in teaching. Many of us may have also learned from him as students. And he's here today to share his experience and his views. And of course, we have Dr. Suraj, Vice President of College, a very senior family physician as well, to also share with us his experiences and his views. So we invite everyone to put in your questions in the Q&A. We noted that there were some questions that were asked about on the first segment. We will take them. We'll try to take them at the end, if time permits. But if we are unable to, we will follow up with a Q&A document. Yeah. So now, just to bring us through the case, I would like to bring us through the case again, and then we're gonna get down to understanding, what should we do in this case. But the case I'm going to share about is basically Mrs. B, a 35-year-old Chinese married lady in a monogamous relationship with her spouse, Mr. B. 5 days ago, Mrs. B met a client, Mr. K, at a business dinner, where they got intimate and then subsequently engaged in unprotected sexual intercourse. And then 2 days later, Mrs. B experienced painful vaginal discharge, and she visited Mr. P, her regular GP, for evaluation. Quite wordy, but I believe if you have read the, I'm just going to take through some of the key points, but these are in the pre-webinar reading. But basically, she's a well-healthy lady with no past medical history. She has gravida para 0, all right? And she only partakes in receptive vaginal sexual intercourse. She denies sexual activity with casual partners or commercial sex workers, and including her spouse. She has 3 sexual partners in her lifetime, and of which the last sexual intercourse with her spouse, Mr. B, her husband, was about a week ago. That was protected. And then, of course, 5 days ago, she had unprotected intercourse with Mr. K. She has she practices a condom as a main contraceptive method. She doesn't know what's a baseline HIV, hepatitis B, hepatitis C, or syphilis status, but she is vaccinated against human papillomavirus 4 and also hepatitis B. She did do her pap smear, her cervical cancer screening, which will be the HPV DNA, and it was normal in 2022. Her last menses was 2 weeks ago. And so far, her psychological state when Dr. P saw her was that she's experiencing work stress, and definitely from the recent encounter, some guilt and regret. She is a busy publicity manager in the advertising firm. She works long hours, including weekends. No relationship conflict with her spouse for the last 3 years, so pretty on good terms. So on examination, the good doctor examines her. Essentially, there's not abdomen was soft, non-tender, and I think the key findings was really that of a purulent discharge and atrocious. And when she did the speculum, there was erythematous vaginal canal with thick, copious, yellowish discharge and the inflammation of the cervix. Okay, so The Dr. P did some tests. So the urine HCG was negative. He did a swab for gonorrhea and chlamydia. It turns out positive for gonorrhea. And also as part of the STI screening, HIV, syphilis, hepatitis C screening was done. They were non-reactive and patient was immune to hepatitis B. So Dr. P diagnosed Mrs. B with endocervical gonorrhea infection. Treatment included the following on the bottom right. So we gave a stat, intramuscular ceftriaxone 500 mg with doxycycline for 7 days, and also ulipristal for emergency oral contraception. And the plan was to do a test of cure 2 weeks later, and to, of course, to recheck the hepatitis B, C, and the HIV status and the syphilis about 1 to 3 months post-exposure. In this case, Dr. P abstained Mrs. B from having sexual intercourse until the test of cure was done, and of course to disclose to a partner for contact tracing and testing, and of course to inform Mr. B about this so that he could be tested and treated. And finally, as part of requirements, Dr. P had to notify MOH as per Infectious Disease Act, and also gave good contraceptive and STI prevention advice. So at this point in time, after Mrs. B went back and was treated, then the story is that Mrs. B was noted by her spouse, Mr. B, to be exceptionally quiet. So Mrs. B rejected his advances for intimacy, giving excuses. And then Mr. B felt that this was after Mrs. B attended a business dinner and appeared unwell. He did not have suspicion that Mrs. B had sexual contact with another person, and he was unaware of Mrs. B's current health issues, but he knew that Mrs. B had sought medical attention with Dr. P. And Dr. P is also his regular GP. Mr. B himself is a healthy man and an engineer by training. So in this case, Mr. B decided to ask Dr. P, about Mrs. B, about what happened to her. So in this case, that brings us to the question, how should Dr. P respond to Mr. B's request for disclosure of Mrs. B medical information? Now, to make it interactive, we have come up with a few questions to get everybody to start thinking and to give your responses. And then we can have a look at how all of us think that the doctor should do in this case, and we can discuss around this. So I'd like to take some time for everybody to invite everybody to take some time to answer the questions. And so what should the doctor do? Dr. P, so option A, Dr. P should disclose to Mr. B that Mrs. B is unwell because she got an STI infection, and Mr. B should therefore avoid sexual intercourse. So the first, he should just disclose. Or option B, he should partially disclose to Mr. B that Mrs. B is unwell, but she's undergoing treatment, and Mr. B should go and talk to her about her health. Or should it be option C? Dr. P should inform that Mr. B that is unable to share Mrs. B information and due to confidentiality. And he should advise Mr. P to avoid sexual intercourse with Mrs. B in the meantime. Or should it be D? Dr. P should empathetically and sensitively inform Mr. B that he is unable to share Mrs. B information due to medical confidentiality. And, Dr. P should encourage Mr. B to talk to her instead about her health. And of course, one way you could do is option E, which is basically no comments. You should go talk to your wife. Don't talk to me. I'm just a doctor. I can't tell you anything. Okay, so maybe we'll end the poll and then we can have a look at the results. So I think all of us should be able to see on the screen. So I think it was overwhelming 95% that, that we chose option D. So with that in mind, maybe I would like to ask the panelists, maybe starting with Dr. Paul Goh, how should Dr. P respond to Mr. B request in this case, and why should he respond in such a way and not the other? Dr. Paul. While we wait for Dr. Paul to be ready, maybe Dr. Eng, you want to share what's your thoughts about this? How should Dr. P respond?
Can you hear me, James?
Yes, we can hear you.
Okay. Two thoughts come to my mind. The first is absolute no-no is to tell the husband a lie or untruth. That will be collusion together with the wife. Number two, we do have obligation to inform the husband he's a foreseeable partner and a victim of a communicable disease. And as we mentioned earlier on, the harm is significant. We have obligation to inform. Number three, the way to inform, like what Prof. Goh reminded us, requires some communication skills. So there'll be three things that I need to talk to the husband. The first thing is that, am I receiving a phone call from the husband, or am I seeing him face to face? If it's over the phone, I'll prefer to see him face to face. And I'll invite him to bring along the wife to see me together. Number two, if you see me face to face alone, of course, that will be increased difficulty. I'll recheck with him what the wife has not told him, and whether how much of it is truth and untruth. And number four, I'll ascertain whether he's well or not well, whether he's having symptoms himself, whether he have any possible dissemination, and that make the case more urgent. Number five, despite your sexual history is always a very tough history to take, I have to reascertain that whether there's any coitus before your test of cure is completed. If I'm certain that he's safe and there's no urgency, I'll re-invite him to talk to the wife first. And if the wife has difficulty, you invite them to come together. So you do a double break news communication setting in a structured, sensitive, empathetic way. Finally, you must give a timeline to others. I probably won't withhold the information for too long, because there's always a risk that a coitus will proceed, and these concepts of this risk of ping-pong infection, whether the husband and harbor a similar infection and pass it to her, we won't know. So in the States, there's this concept, even in the state, it's not uniform. There's this legislative concept, legal obligation for physician to call duty to warn. I think this is not tested in Singapore. I think Mr. Lake can comment and input. So I'll call this obligation to inform, to prevent harm. So Prof. Goh has taught me the virtue of family medicine. The strength of family medicine is that we are probably the only practice that look after family horizontally across the same generation, vertically across the different generation. But now I realize it's a double-edged sword. Now we have to handle the concern, the privacy of one patient. And just now, Prof. Thiru mentioned, right, privacy in the Charter 2008. One is privacy to patient in the case to the wife, but also honesty to another patient, which is husband. So we have to reconcile this in terms of obligation to inform to prevent future harm. Thank you, James.
Thank you very much, Sook Yang. Dr. Paul, thank you so much.
Yeah, sorry, I was locked out. Hello?
Yes, we can hear you.
Okay, so you asking me to comment on this question. I think it is quite clear that we are obliged to respect medical confidentiality and not disclose information obtained in confidence or in the course of attending the patient without the patient's explicit consent. I think, however, there is such thing called implied consent. For example, if the husband was with the patient, okay, then in that case, it is implied that you can disclose the medical information only during the consultation, because subsequently, you may need to actually get a consent of the patient as well, because the patient may be agreeable to information disclosed during the consultation, but not subsequent results. So that one we cannot assume, okay, and we cannot imply on that. Yeah.
Thanks, Dr. Paul. So that's definitely something that is important, that just because the husband and wife came together in that visit and there was implied consent for the wife to share, for the doctor to share information freely, and there was no, it doesn't mean that after that it was implied consent that will hold throughout subsequent to that. And it's important for us to ascertain that. And so in that case, I think Dr. Ng shared about a couple of information that the doctor should obtain in order to make the assessment. And I guess one of them is to really find out, for example, like what Dr. Ng mentioned, is to find out about what does the husband know, and then also what is the proximity. I mean, what is the risk of getting a sexually transmitted infection, and then there's the duty to warn aspect as well. Dr. Suraj, can you let us know, like, so under these kind of circumstances, what should the doctor, what kind of information should the doctor obtain to make this kind of assessment as to whether he should disclose or not disclose, given this setting?
It is a difficult question to answer because the doctor is a doctor to both the husband and wife. So I agree with all the points that were raised, but my personal view would be, if the husband were to call the Dr. P, to ask this question, of course, the answer that is chosen, the answer D, is correct. But I would at the same time also would follow up this by calling up the patient, the wife, and asking her again, that informing her that the husband has also asked this question, because it is pertaining to medical confidentiality. One of the things that sometimes communication needs to be very sensitive. So, of course, in this situation, you could, one of the things we can encourage is to ask the wife to discuss with the husband if she would be so inclined. In other words, to come clean, right? That would solve one problem, but many times they won't. And so she would then categorically tell you that she still wants it to be maintained as medical confidential. Then you have re-stressed again that confidentiality is important. Now, the other aspect is I think there's a question raised in the chat that it's also been determined that the husband has not had any sexual activity with the wife after she had the extramarital affair. So there is no currently, based on your assessment, there is no current immediate danger to the husband. So that's one factor to consider as well, to try and get to talk to the wife first, right? But on the other hand, if the husband had already had a sexual intercourse with the wife after she had been exposed to the extramarital affair, then there is some form of risk to the husband. And then this question becomes more sensitive, more difficult to answer. Again, I would still approach the wife and see whether the activity did actually occur. In others, with the husband, did she actually expose her husband to the infection? And then try to resolve this conflict between the two of them. But I'm open to other opinions. Maybe you can ask Prof. Thiru. Yeah.
Okay, I think in this case, taking the case, can you hear me?
Yeah.
Okay, taking the case as been stated, right, in this context, I think the majority of the people got it right, because you should recognize the concern that the husband is actually concerned about the mental health and behavior, right? So that is actually your focus in terms of any discussion you want to have with the husband, right? So, and secondly, if you've taken the sexual history and it's correct, the husband is not at risk. So there's no risk to him, and therefore you really do not have any ethical or legal basis to breach confidentiality here. So the question, so I think that was really the summary of it. I don't think we should be fussing around about, if and when and this. I think you need to get your facts right. You need to, I think, give the treatment as was done correctly to support her in terms of the wife. But also when the husband comes to recognize that she has a problem, and it's best that he speaks to her, and unless she would like to come together with the husband to actually discuss the issue. I think those are the important things. So I don't think we have any basis to breach confidentiality on the harm to others or any other basis. Over to you, Suraj.
Thanks, Prof. I
Yeah.
think Dr. Ng mentioned about the duty to warn aspect, and maybe I can invite Mr. Lik to talk about this duty to warn, and in the medical legal context, how would this affect us in our practice and from the legal perspective?
Okay, so for this case scenario, Dr. Paul Goh did also mention whether we can consider whether we can find a way out through implied consent. I understand where that is coming from. At the same time, that can actually, and including the duty to warn, can actually be tackled by, as Dr. Suraj has opined, just talking to Mrs. B directly and say, look, there's this issue, your husband is concerned. Would you allow me to talk to him about your condition? Okay, of course, if she says no, then actually, as Dr. Thiru has said, I mean, that basically is it. Okay, of course, at the same time, it's all right for the doctor to go and advise Mr. B to please speak to the wife, okay, because he has, I'm telling him that you, the doctor, have a duty of confidentiality. Okay, so I think this case, I don't really see that there's any way to really depart from answer D. Okay, I mean, the duty to warn, there is, well, there is such a concept, but it may not be applicable here. No? I mean, one way of looking at it is this. Okay, there probably isn't such a duty which will override the duty of confidentiality, because when you look at it in the Singapore context, what is the one distinct and so far only accepted area where you can actually go and disclose? HIV, right? You see, there's only one legislator. Okay, there may be others, but I let the panelists tell me. But is it not, I wouldn't say unusual, I mean, isn't it significant? Actually, the law only provides for one, which tells you something, right? That means the duty to warn may not override the duty of confidentiality in practically all other circumstances. Okay.
Thank you, Mr. Lik. Dr. Ng, I think you raised your hand. You would like to chime in.
So I agree with Mr. Lik, because the duty to warn is not tested in Singapore. So at the meso level, macro and micro level, things will be less complicated and easier for the doctors involved if, number one, you recognize that at the meso level, there's no single ethical principle that's absolute, meaning no single principle, whether it's confidentiality, autonomy, or beneficent, is correct all the time at all cases. And the macro level, you have to understand in this case, what's the limit to the principle. In this case, confidential limit, I think Prof. Thiru and Prof. Chong Pat Yen has published almost 10 situations where there's limit. In this case, there's potential harm to the husband. And the micro level would be the easiest thing to do to safeguard, to make things easier for us, is that when the wife first, even before the husband call, when the wife requests that you not tell the patient, do not promise the wife that you will withhold the information from the husband or tell the patient a lie that there's no STD. This will found the basis for and document it. This will make it easier for subsequent encourage disclosure or helping the wife to break bad news to the husband.
Thanks, Dr. Ng. So we can see that from the responses from our panelists so far is that it's really contextual and really about assessment of the risk, and therefore the duty to warn and the duty to disclose. So I think Dr. Suraj also mentioned about, Prof, you wanted to chime in as well, Prof?
Yes, I want to say something very clear here. Confidentiality is not just about an individual person's privacy. Confidentiality is also a public interest. We want to make sure that the public actually trusts in the healthcare system and the profession, that whatever important information that they share will not be used for anything other than for therapeutic purposes, right? except when it very clearly is required by law or harm to others, you can say, right? So the default mode should be you keep confidentiality, right? My practical advice, if you are not sure, please, this one I mentioned earlier, have a good relationship with your senior doctor or somebody to say that you, how shall I deal with this case? And don't try to be a lone hero. Sometimes the moralist in us, sometimes the moral police in us will tell us to go and share this information. So I'm trying to make a very strong point here. Then we have to guard confidentiality. And it's very difficult that we, in this case, without the consent of the wife, to share some information, right? And I would really not try to put myself in a difficult situation to try to bring them together unless the wife gives consent very clearly. We want to come together, and can you please explain to my husband? And you must then warn her again of the risk. And if she's aware of the risk, then I think you can get into such a mediation or whatever conference you have. So I think that's something that we have to realize, that confidentiality is about preserving the confidence and trust in the profession as much as preserving the person's own privacy. Over to you.
Thank you, Prof.
Yeah, sorry, maybe I would just want to add. I keep being locked up. But anyway, I think we should be slow to decide to breach medical confidentiality unless we can ascertain really there is really very serious harm and urgent situations. Because if the threshold of this disclosure is too low, especially in the medical community, what can happen is that it may erode the relationship of trust between patients and doctors, because I'm not sure, the doctor, his threshold may be very low, then he will just breach the medical confidentiality easily. So I think that is something very important to know. Whatever it is, I think we must have very sound justifications if we want to disclose patients' information without consent. Right.
Thanks, Bob. I think that's something that's definitely important and mindful for us to remember. There's always this weighing between the trust between the patient has in us, but also our duty to the general public. I think Dr. Surachit mentioned about there are certain circumstances that actually may shift this duty to warn, duty to disclose. And then one of the things is that if the husband was symptomatic, or the husband had sex after actually the sentinel event. So, Dr. Suraj, would you like to share with us? Is there any other situations that you think will also shift that duty to warn as well to actually disclose? And how can the doctor make the judgment in this case?
I think if the risk changes, then the duty to warn would also change. But I think if we're dealing just with this particular infection, which is not life-threatening, for example, if it was HIV, then we are talking in a different context. Then there is a duty to warn by law, right? But at the moment, if it's just this particular infection you've taken in this clinical context, then you have to weigh the risk of the husband's medical interest. I mean, the interest to the safety aspect to the husband as to how bad the infection would be if he's exposed. And so I would think that would be the main reason for me to shift the responsibility if the risk is changing, if the risk changes. Otherwise, as it is, I don't see any other revenue out. There was a question in the chat, I think, which I just answered. What if the wife gave consent to disclose to the husband? Actually, that's also tricky. I'd rather the wife disclose herself rather than the doctor disclose. And she gives us permission to disclose, and then the doctor is the one who's going to disclose to the husband, where the wife is not given any written consent. Right? It's always better to encourage the wife to disclose to the husband and to repair any relationship issues, rather than the doctor acts as a third party to disclose on behalf of the patient. So yeah, that's your question. I'm open to other suggestions.
Thanks, Dr. I mean, on that note about that question on the about getting actually written consent, Mr. Lake, would you mind to share with us what's your legal perspective on that? I mean, how far does that go to actually safeguard the doctor in terms of disclosure? If let's say he were to get actually a written consent.
Okay, so the key issue is that, well, as a fact, did the wife give consent? So whether it is documented or not, right? And in a case like that, I suggest you get it documented. I mean, it's just basically the quality of the evidence. Of course, you at a minimum, you must document. So the wife tells you over the phone, for example, yes, I consent, I agree. Then at the very minimum, the doctor needs to document it himself in his clinic notes. Okay, at this time, wife said what? Consent to disclose what? Okay, so that in most cases should be sufficient. Sometimes because of the circumstances of the case, a doctor may very well feel that, wow, for this, maybe there'll be fireworks after that. He may choose to decide that because of the characters involved, he might want to invite Mrs. B to come down to his clinic and go and sign something in the clinic notes or something. Okay, but that's really the quality of the evidence. But there must be at least documentation about this consent in the clinic records. Okay.
Thank you.
It is advisable, of course. It is advisable. Yeah.
I think there was a live chat. I think the question in the Q&A that, whether or not MOH will actually contact the patient's Mr. B, since that, the notification was done. I believe that that's not always a guarantee. The contact tracing may not occur, so we shouldn't assume that the patient, or rather Mr. B, the contacts may be contacted now. I think that's one.
Yeah. Actually, for gonorrhea, I think the notification doesn't contain the name of the patient. You don't have to put the name of the patient. It's more for epidemiological and statistical sort of surveillance rather than for contact tracing.
Absolutely right. So I want to echo what Paul says, right? The purpose of notification is for epidemiological reasons. Other than for HIV, the ministry is not going to inform or contact trace anybody, all right? I'm not sure if your patient goes to Rantan Polyclinic, then you may have some contact traces to help you. But just to reiterate, whatever information that you notify in the Infectious Disease Act is actually under confidence. That means whoever receives information, right, will have to maintain the confidentiality even at the MOH level. I think you all know the famous case about the HIV doctor and etc. In terms of sharing information. So again, to emphasize, the purpose of this is for epidemiology, other than for HIV. It's a non-nominal form, and it was designed a long time ago, and that goes back to the wisdom of the Singapore Ministry of Health and doctors working in SCD.
Thank you, Prof. So I think there's also an interesting point is that, if you were actually, in this case, if I think one of the participants, if in this case, Dr. P called after hearing from Mr. B, then called Mrs. B to inform her about this, would he be breaking the confidentiality that Mr. B and Dr. P has? So I think that's, what do the panelists think? Dr. Paul, what do you think? Should he not tell Mrs. B because the Dr. P also has a duty of confidentiality to the husband, Mr. B in this case? Dr. Paul, you're muted.
Yeah, sorry. You're talking about Mr. B, right? So
Yes.
if Mr. B has symptoms and is seeing the doctor, there's a separate consultation, nothing to do with actually Mrs. B. So it should be treated as another case of confidentiality. There shouldn't be a discussion of that the source is from your wife or whoever, right? So we should keep them apart. It is a separate issue totally. It's like another patient.
In this case, would let's say in this case where the husband came and to ask about the wife, and the doctor, after hearing about the husband's concern, calls the wife to tell him that, oh, your husband came to talk to me about your health, would the doctor be breaking the confidentiality of the husband that he himself?
Yes. So in fact, you are not supposed even to reveal whoever comes to see you. So like, for example, even in our practice, we have got HR personnel or employers who actually call up the clinic and ask, oh, did this patient come and consult you? If you look at the ethical code and guidelines, you are not even supposed to reveal that this person actually came to consult you, because sometimes it may be a psychiatric condition, it may be like a sexually transmitted infection kind of. So I think it's important that this is also considered as medical confidentiality, whether the person actually consulted you or not.
Thank you, Dr. Paul.
I would just add, even if your wife is a doctor, asks you the question, do not answer. All right. So I think this concept of confidentiality, consciousness is going to be is something that we have to inbuild in ourselves, and don't allow other boundaries to blur it. And I agree with what Paul says. It's in other words, when you call the wife, you're actually speaking behind the back of the husband. So that's breaching confidentiality, right? So remember, the path to hell is marked by many well-intentions, right? Good intentions, they say. So I think this is an area where we cannot and the default mode is maintain confidentiality. If you are sure and have got strong reasons like consent, write it down, document, do it. Otherwise, I would strongly advise practitioners to consult somebody else if you are not sure before you proceed further. And even if you want to call Mr. Ling or your insurance company, fine. But the default mode is maintain confidentiality.
I think there was a question by one of the participants who just typed in and say, for patients below 21, if let's say this was a adolescent or maybe below the age of 21, and then the parents called. In this case, you know, does the doctor have the does the doctor, you know, does the doctor need to actually disclose to the legal guardians, in this case the parents? Maybe Dr. Ng, you want to comment about this? I think it looks like it's something that a lot of participants are concerned, and a lot of interesting scenarios that are relevant.
The patients that's infected is below 21, but above 16.
I would, that was the part that is also a weighing factor that will decide.
So as
let's not take it that it's above 16. So
yeah.
I think below 16 is quite clear.
Okay. So as a general rule, the younger the patient is, the more you should involve the parents or legal guardians. I think we can confirm with Mr. Lake that Gilead principle is not tested in Singapore yet, but as a 16-year-old and above to 21, I think if they are given consent to sexual activity contest, I don't think it's illegal. And we also have to assess the patient's individual capacity, whether it's have any intellectual disability, and whether there's any hidden coercion or cases of abuse. Then in that case, the more we should rope in the parents, social agency to assist her. But if the patient is rather independent, there's this US concept of emancipated minor. Let's say they have served in military, or is already a parent to and caring for a child. You can accord them more independence. Did I answer your questions?
Thanks, Dr. Ng. Dr. Paul, would you like to share your insights on this?
Yes, I think it is again patient's best interest all the time. Okay, so you have to establish what is patient's best interest. Now, if it is a minor, then if let's say the involvement of the parents or the legal guardians is important in the management of the minor, then you should involve the parents or the legal guardians. Because again, it is always about the patient's best interest. Because as a minor, you don't know, you may want to involve their legal guardians.
Okay.
Right.
So it sounds like it's not a straight off, but it's really about weighing what's in the best interest. We also recognize that minors also have the right to decide, but also depending on what is their mental capacity, right? And then Gillick's competency is one of those tests that we use to assess whether the minor is mature and able to understand. I'm mindful of time, so why not let's move on to the next question. So now, so in this case, all of us, 95% of us advise Mr. B that, we can't disclose this, and we ask him to speak to his wife to find out more. And of course, Mr. B is visibly unhappy because of the refusal, no matter how empathetically and sensitively and professionally you have broken the news to him. And then he says that, look, we always see you with my wife together, and we share when we are present, and so we share knowledge of each other's condition. Then he asked him, why should you then withhold information about my wife from me now? So maybe we can launch a second poll. I think some of this has been discussed, but let's hear from our audience. What do you think we should do in this case? So what should how should Dr. P respond? One, he should then agree and then apologize for the oversight and then proceed to disclose. Or two is to explain to it that, in Mrs. B's absence, he cannot assume implied consent. And, he should inform Mr. B that he will need to get Mrs. B consent. He will need to speak to his wife. And then, or he could explain to Mr. B that, since the wife is not here today, he can't disclose anything. So rather than talk to him, the husband should talk to the wife. And of course, the option D is that, you can tell him that the law forbids him to disclose any information. The doctor can't tell him, the law doesn't allow him to. So if anything, the husband can write to MOH to seek information on his wife. Or the last is that, the doctor should empathize with him and then say, okay, I'll write to DGH, MOH to ask for you whether I can disclose your wife information to you. So I think we have discussed some of this. So let's just wait a little while for maybe another 5 more seconds for some of us to put in our views. And then I think some of this has been discussed. So let's see how has that shaped our responses. Okay, so let's end the poll and let's share the results. So 87% of us explained to him that, chose option B, which is, you cannot assume implied consent. So he will need to get explicit consent from the wife before telling the husband anything. But there's also about, and there's also 11% of us to say that he can't disclose. So don't talk to me, talk to your wife. And of course there's a 3% that feels that he should go and the husband can write to MOH. So maybe I at this point in time, maybe I can ask Suraj, Dr. Suraj, what do you think in this case? What are the responses that the doctor can do?
Yeah, so it's correct. As long as if they apply if they attended the consultation together, both the husband and wife, then information is disclosed in front of each other, then there's implied consent. But other than that, and Mrs. B is not present, you cannot assume there's implied consent, right? And one would have to ask Mrs. B specifically, as I mentioned earlier, talk to the wife if the husband comes to ask certain questions about what's wrong with her, what's the condition. So I think answer B is correct. Communication is very important. I think being a family doctor to both the husband and wife, you might want to always try to encourage them to disclose, the wife to disclose to the husband. All right. And as I mentioned, to repair any relationship rather than the doctor be the person to break the news. So therefore, no matter what, no matter how unhappy he is, I think you can't disclose anything. And there is a question, maybe I can bring in the question that's not answered yet. Suppose he gets an infection later on, can he sue you for not disclosing the information when he asks for it? Maybe that's a question for Mr. Lake.
Yeah, thanks Suraj for sharing that. So, okay, I guess you brought up the question. So maybe Mr. Lake, would you like to share your thoughts about that question from the from one of the participants, that if let's say the doctor decide on.
in the case that the husband gets infected.
And then the husband gets infected, can he subsequently sue the husband for not for this
The doctor, yeah.
duty to warn part, the failure for the duty to warn?
Yeah, so I don't think that there is a duty to warn in such circumstances. Okay, so in fact, the duty of patient confidentiality to Mrs. B would override whatever duty that, so to speak, to talk to Mr. B. So if there's such a suit, it wouldn't succeed.
Thanks, Mr. Lee. So I think the thing about it is that really having a good assessment, good documentation, and also good communication as well. It's not easy. You straddle between both family members who are both your patients in this case. Now, we got, how about, oh, Prof, yes.
I want to emphasize this point about implied consent. Just because they come together, it doesn't mean you can blurt out everything, right? Because it is quite clear, even in the NEHR, we have what we call sensitive issues, right? Whether it's mental health or sexual health or any of those things that are mentioned. Under what in the profession we know are sensitive issues, sharing which may lead to foreseeable risk and harm to relationships, right? So doesn't mean the husband and wife come together implied consent, or even family members, you can straight away go and share. So it is important that if you want to discuss something that is foreseeable or is classified as a sensitive area, then I think you got to pull each one aside and say, hey, is it appropriate to share or not? So sometimes in a joint consultation, family members, it is quite normal to say, can you please excuse me? I would like to spend some private time with my patient. All right, because again, you can see that when people come together as a family, there could be a coercive relationship, right? So I just wanted to say that don't go away the idea that come together, implied consent, you can share everything. And I think the point that about the husband getting infection comes back to is really the competency. Have you been competent in getting a good sexual history and defining who is at risk, right? And if you have taken a good, what shall I say, an accurate sexual history as best as you can, and you have documented it, then you have done your job as far as your duty is concerned. Over to you.
Thanks, Prof. So I think it's like what we spoke in the first panel is to have, like what Dr. Swan mentioned, to be clinically sound and clinically good in what we do, and of course to communicate well. So maybe the other panelists would like to chime in this case. I mean, is there anything that the doctor should take note of, and how is there any way that the other ways that the doctor could respond as well?
No, I just want to add, because I think there is a certain percentage of people who chose C, right?
That to just yes, to say that they can't discuss anything and then just speak to your wife.
Yeah. This, I don't know, this borders on an issue of your attitude, behavior, and professionalism, isn't it? Of how you handle patients. So
I think Dr. Paul put this important point about just being professional is one, and I think it's also the pitfalls, that just by being professional and sticking to our professionalism, sometimes we still can get into trouble because somehow the communication part may not be fully addressed as well. And that's also the soft part, is also the IQ, EQ are both important. I'm mindful of time, so I think there are some questions that we have answered in the Q&A. So I think if there's no further questions, I think that will probably bring us to the end of the case discussion. I think we just wanted to use this case and we're very glad that there's a rich discussion from the participants and also the panelists about this case. But I think some takeaway points that I think we have gleaned is that one is that preserving medical confidentiality is an obligation because it's about patient autonomy, and patients have the right to decide. And we need to, and there are exceptions, but we need to be very clear what those exceptions are and when we can disclose them. And we need to make an assessment. We need to be justified clinically and ethically and professionally as well. So we do need to know what are the various acts, the laws, and also what does our ethics say. So what does our profession says about this, and what does the law say about this? Such as in the case of HIV, what does the Infectious Disease Act mention, and how is it different from other conditions as well? And then it's also, this case also highlights the uniqueness of our family physicians. We take care of a whole family. We see each family member, but yet we take care of the family as a whole. So how do we manage this issue of confidentiality, information sharing within each family member, and also is unique? And I think the panelists have alluded to that we need to take each family, we need to manage each family member on its own, and we need to maintain confidentiality with each of them. And then if we do disclose, it has to be contextual, and we need to really make an assessment. We must consider point 7 to consider the context, the nature of the information, whether it's implied, and then what's the risk and benefit to both the patient and the person who is asking. So I think with that, thank you very much. And that brings us to the end of the second part. So I'd like to pass it back to Dr. Suraj to close the session. Thank you very much, the panelists.
Yeah, thanks, James. Yes, I think even though we overran a little bit, I think it was a very interesting webinar. And as I mentioned, it is the harbinger for more to come next year when the CME in ethics becomes compulsory. And we will try to make it, learning from today's, please give us your feedback, because we want to refine the webinars and all the other activities that we are planning next year so that we can improve. We particularly want to make it interactive, and will invite questions from the participants in the audience. And we will be using more case scenarios, particularly in the context of family medicine, to illustrate all the principles that we are trying to bring forth during our subsequent webinars. Now, I would like to thank all our web panelists today. Very valuable insights given by them, and very good discussion points. And I would also like to thank James in particular, because James was the main organizer for today's webinar. James and Rose behind the scenes, Rose Falk, for helping us put together this webinar, and not to forget Chester, who's part of the college secretariat and helping us with the technical expertise. Now, without much further ado, I'd like to call this webinar to a close, and we will see more of you next year when we plan more activities. So have a good evening and a pleasant weekend. Thank you, everyone.
Thanks, Dr. Suraj. So for those of us, if your question has not been answered, we will put together, we will try to answer them, and we will send it out as a document subsequently.